Good morning, everybody. Thank you for being here. Thank you for listening in online. Thank you for joining us for today's Vodcast. And thank you for the Prostate Cancer Foundation of Australia for partnering us with this. For those battling prostate cancer, the term Scanxiety carries a profound weight, with the emotional whirlwind of undergoing numerous scans, awaiting the results, confronting the unknown. The purpose of today's podcast is to really address the emotional challenges faced by cancer patients during their imaging journey and explore how advancements in diagnostics and imaging technology are not only enhancing the precision and understanding of the disease, but also reshaping the patient's experience and overall patient experience throughout their journey. My name is Matthew Britland. I'm the Managing Director of MedWise, which focuses on patient engagement, medical communications. I started my career 25 years ago in cancer at the Christie Hospital in Manchester, and I vividly remember how profound this issue has on patients. The implications are large. A mere 2 months ago, the PCFA hosted a webinar on Theranostics and you. This serves as a perfect segue into what we're talking about today. We are deeply honoured to host Professor Rod Hicks, the founder, CMO of PreMIT, also a key opinion leader in his field of nuclear medicine and oncology globally. Dr. Paul Conway, a renowned radiation oncologist from ICON, Katherine Lyons, a clinical nurse consultant at the Melbourne Theranostic Innovation Centre, and I and Will, who needs no introduction to, I'm sure, anybody who's listening to this, Will McDonald, Nine news presenter and journalist who bravely faced a diagnosis of advanced prostate cancer 3 years ago. So let's start our discussion by understanding from a patient's perspective, Will, what we're talking about today. Could you please share your experiences with cancer imaging, Scanxiety, the emotions, but also things like the toxicity, the financial toxicity, other things like that are associated?
Yeah, absolutely. Thanks everyone for listening in. Thank you, Matt, as well, for the introduction. It was really didn't start off scary for me, the whole idea of Scanxiety or having scans. My prostate cancer kind of popped out of nowhere. I didn't have any symptoms of prostate cancer. What I went along to have is an MRI to try and figure out what was going on with my left hip joint, which was increasingly sore. I was kind of happy to go along and find out what was going wrong, but that was when all of a sudden the MRI came back with telltale spots of white lesions on the scan, and all of a sudden, fast forward a few days, so I've ended up with advanced prostate cancer. From there, that's when things escalated quite dramatically. I hadn't heard of most of the things that were going to happen to me, from biopsies to PSMA PET scans to bone scans to all that sort of stuff. I think it really became alarming, or I guess really started to play on my mind when, after a biopsy, they then wanted to send me along for this thing called a PSMA PET scan, which was going to figure out whether or not the cancer had spread even further than what we already knew had happened. The scan itself, I guess, wasn't scary. I think the thing that I found the whole way through, no matter how many scans I've had multiple MRIs, I've had 3 PSMA scans, I've had a whole bunch of other things, X-rays, all sorts of stuff. I think it's not the scan that I find scary, it's the waiting time after you've had it to find out what has gone on. So that's the real mental battle for me, and I suspect that's probably very similar for a lot of men as well. I try to use the idea of the scans are really going to help fight my cancer as best I can, but nevertheless, no matter the positive mindset you can put yourself into, I can tell you that this is what I need to do. There's no doubt that going through these processes, sitting in those big metal tubes, having people come into the room with you and then quickly leave and shut a big thick door behind them, you start to feel that it's not a fun place to be, no matter how well you can set your minds before you get in there. So yeah, for me, it's the gap between having the scan and finding the result, which is the anxiety, and you really have to work on trying to calm yourself down, I think, for lack of a better term, to try and just get through that stage. Financially, it's can be quite brutal. I remember when I had my first PSMA PET scan, it was basically $1,000 up front. And I was fortunate, I guess I had that sort of money in the bank, but it was still very difficult for me and my family to all of a sudden just shell that out. And then 6 months later, I had to pay for another PSMA PET scan, which was another $1,000. So you quickly start to add up the cost in your head, going, oh wow, this is going to go on for a long time, and there's not really anything you can do about it. You need these scans, so you know this is a cost that is going to continually probably hit you for many years to come. So that does start to weigh as well on a patient. I'm sure that it's not just the cost you pay right now, it's the cost you know is going to come into the future as well. As advancements are made, you want to get the best and latest technology, but you know it's potentially going to become more and more expensive to keep fighting cancer the best way that you can. I guess from a perspective of the way I try to look at going into, whether it's an MRI, PSMA PET scan or whatever I need, it's information that is going to be powerful in the way I treat my disease. It's far better than what we had in the past. I mean, PSMA PET scan is an amazing piece of technology which helps men really pinpoint what their cancer has done and the best way to fight it. So I really go into it with the mindset of this is information, and that kind of helps the anxiety a little bit. It's not going to change what's going on in my body. Not knowing is not going to make it better. I think if I can have the idea of information's power when going into these things, that certainly helps my anxiety a fair bit.
Thank you. Well, we'll certainly be touching on a couple of things you've just said there, but I did want to introduce Professor Rod Hicks. So Rod Hicks is an absolute world-renowned leader on nuclear medicine, but also particularly the development of Quadra, which I believe you had a large hand in actually designing, if I read rightly. So I don't think there's anybody probably more qualified, Rod, for you to give our audience just a flavour, just an overview of what your thoughts are. How have we progressed? Where have we come? Where do we need to go to? And can you give us a little bit more information about what you've developed down there in Melbourne, how that's helped patients from both the Scanxiety of the procedure itself, but also reducing times that it takes to get reports back and that communication and education?
Thanks very much, Matt. And that was a wonderful overview by Will from the other side of the camera. I sit on the outside, he sits on the inside of these scanners. And having worked in the nuclear medicine area for nigh on 40 years now, and 30 years building what I think is one of the world's best nuclear medicine programs at the Peter MacCallum Cancer Centre up until I left at the end of 2021. I had the opportunity to access this amazing technology behind us, which is the Siemens Quadra scanner. What Siemens did was to take their very best digital detector technology, which has a field of view of around 26 centimetres, which for a PET scanner is actually quite long, and add 3 more banks of the detectors behind it, giving an overall length of detectors of over 1 metre. And that brings incredible research opportunities to us from the point of view that we can follow the passage of a radioactive tracer from the point of injection through the entire body, looking at the brain, the lungs, the heart, the kidneys, the liver, right down to the pelvis and upper thighs, where the majority of cancer is. So we can detect its uptake both in the cancer deposits, but also its distribution through normal organs. That's a fantastic facility. By increasing the length of detectors around the patient, we dramatically increase the sensitivity of the scanner. It's tenfold more sensitive than even the best digital standard field of view, standard length of scanner, which itself is twice as sensitive as most time-of-flight scanners in the hospitals around Australia. And those time-of-flight scanners are, again, twice as sensitive as some of the older PET scanners that are still in use in Australia. So somewhere between 20 and 40-fold increase in the sensitivity of this scanner makes huge differences to how quickly we can do scans, the number of scans that we can do in a day. And that has some advantages, I think, for patients who are anxious about having to wait for a scan. You get a new diagnosis of prostate cancer, you want to get on with treatment as quickly as possible. So you want to have as quick as access to the scan as possible, or your PSA recording has gone up when you were hoping that you were cured by the surgery or radiotherapy you've had, and you need a scan to assess when or what the next step in your treatment is. Is it localized and can be treated with salvage radiotherapy, for example? Is it more extensive and needs a wider field of radiation? Are there a limited number of secondary deposits that might need treatment? Or is it a systemic disease that needs early treatment with hormones or chemotherapy? All of those things create anxiety if you have to wait. The other thing that we're concerned about with this scanner, that its dimensions are very much like an MRI. And I know from long experience that many men have great difficulty with just the sheer length of the scanner, feeling claustrophobic, boxed in. They get anxious about that, and it's uncomfortable because it can be quite a long scan. And so in designing the department, we really wanted to make sure that we made the patient experience as favourable as possible and try to overcome some of those theoretical issues. And that's an area where Kat has done an incredible job with a nurse-led program to deal with those issues of the sheer scale and size of the scanner. And perhaps, I'll hand over to Kat to perhaps talk a little bit about how she's gone about that.
I think that would be firstly, thank you. It's wonderful. I'd love to talk to Kat and say, the nurse consultant and the nurse practitioner in Australia has become so important, and more so, and the more we see this investment in cancer, where nurse practitioners, nurse consultants are employed in, we're seeing better outcomes. So firstly, congratulations on securing this important role. I'd love to go to Kat, but also at some point come back, Rod, and talk about the need, because again, when I was working in practice 25 years ago, we often had to pre-medicate patients who were going through traditional scans. And I'd love to know whether that this has had an impact, because that's not much fun for anybody needing to be pre-medicated. I'd love to maybe get back to that, or you can address that now if you've got a Kat.
I'm really happy to talk about that. When we were preparing our medication list, we put lorazepam as a way of reducing the anxiety that patients had when they came in if they were severely claustrophobic. And our impressed supply of that medication expired without us using a single dose, which to me was just absolutely remarkable, because we'd had many patients coming in and saying, I've never been able to tolerate a PET scan before, or an MRI. I'm very claustrophobic. I definitely need to have sedation. And the work that Kat's been doing is in walking the patients through the process has meant that we haven't had to do it to give sedation. Occasionally, patients have taken benzodiazepines before they've come in because their previous experience, they knew that they could tolerate it better. But really amazing reduction in the need for sedation. The other factor is that the scans are so quick. That the routine scan that we do for a PSMA scan on this device is 4 minutes. And if we need to, we can reduce it down to 30 seconds. We've reconstructed the data that we can do from head to the upper thigh in 30 seconds with a scan that is superior in quality, in my opinion, and having seen over 100,000 PET scans in my working life, I think I have a fairly good judge of the quality of the scans. They're just really remarkable. I don't think I imagine when we were working through with Siemens in a project, it was called the Raptor project. It was sort of a top secret project about developing this. And the detectors actually have a little decal of a raptor on it, which I think is kind of cute. But when we're working through it, I didn't imagine it would be quite as good as it's turned out to be.
pretty impressive. You have to give a whole box of lorazepam back. And I'm very fascinated, Katherine, in what you're doing. I mean, this is, I think, again, so much best practice could be learned from this. And I'd love to talk to you about what you're doing from a patient level. You're leading various different programs. You're researching this. You seem to be ahead of the curve in terms of trying to understand this. How are you doing this? How are we educating patients? How are we, again, I'd love to ask you about how we educate patients on the results as well.
So first of all, when Rod asked me to come to MTIC, I was thrilled by the opportunity to work with a group of patients and actually look into Scanxiety, knowing that this PET scanner does have a longer length and can be similar to an experience that a patient's had with an MRI or a PET experience, because they've had to be on a scanner for a really long time and had half an hour. So I really wanted to tap into that specific area and looked into a topic that's been around for 10 years, Scanxiety, but it's been researched in patients who've had MRI scans, and they've looked at the various amounts of areas that are contributing to Scanxiety. So the claustrophobia aspect, the topics that Will has touched on, such as the financial burden, the new diagnosis, and trying to understand that having multiple scans, depending on the information that's just been provided to a patient from diagnosis or change in presentation to have I got a new symptom, can all factor in how they come on the day of the scan. So no to the same scan on the same day and another scan on a different day using the same scanner may not have the same patient experience. So what we've tried to implement here at MTIC is to have a nurse-led service where we're calling patients who are being flagged in the referrals as claustrophobic, and we're actually trying to unpack prior to them coming to the scan what is influencing how they're feeling. So what are they worried about? What's impacting on how they feel? Have they received some bad news? Are there family factors that are impacting on how they're feeling about their diagnosis of prostate cancer? And then how previous scans have gone for them. Have they needed sedation? And sometimes just explaining to them that the scan is going to be 10 minutes and you're in a well-lit room that many patients have said feels like a warm hug sometimes, and where they can see the views of Melbourne as they're in the scanner, gives them a distraction. So they're not having to introspect when they're on the scanner for 10 minutes or 4 minutes. We've also implemented the use of what I would like to say, these goggles. So when patients are actually lying on the scanner, they don't have to feel the top of the PET scan. They can actually look out and see views of Melbourne, which when they're coming off the scanner, they're telling me that was actually a better experience than I expected. And a lot of patients, when we've gotten feedback, they've said they've felt more comfortable because as they've come in, we've actually addressed some of their needs, some of their anxieties. We've given them the time prior to the scan to just sit there and be able to calm themselves down. And then once they're on the scanner, we've got a lovely team of nuclear med technologists who've been in this field for a really long time, who actually also make sure that the patient is comfortable before we get them into the scanner. We also introduce music into the area so that they can feel comfortable. And so rather than being a room with a closed door that's dark, as Will mentioned, we can give time countdowns through the scan. So we'll usually give a countdown of 1, 2, 3 minutes. And so all of these new techniques have been used to kind of minimize that anxiety that they have pre-scan. We also then reiterate that usually you'll expect a result from us within 24 to 48 hours, which allows patients to kind of have that ease that I know when I'm going to expect my result, or when I can expect my result, which is sometimes that communication at the end. You've had your scan, now what? That adds that anxiety. So we're looking at from factors that happen before the scan to what's happening in the scan, as well as how we can help them after the scan. And we're always willing for patients to call us. And I think, if they're before a scan and they just want some extra information, we'd like to keep that open dialogue because it's a patient-centered approach. We want patients to feel empowered, and we want them to make sure that they, if they're having any worries or anticipating what's going to happen in the scanner, that we can alleviate them before we get to a point where we're having to use sedation, which is risky in itself.
The patient feedback has just been amazing. I recall one of our very early patients from Tasmania had the raw woolen beanie and the Def Leppard beard, and I walked in and said, "How did you find that?" And he said, "Mate, it was effing awesome." The last PET scan I had, I was lying on the scan for it seemed like hours. I was stuck in a dark room. It was shocking. I barely felt I got on and off the scanner. He said it was just so, and that sort of really brought it home how important that patient-centered environment is, the support that our nursing staff, our technologists give to the patients to reassure them as they're getting into the camera, and also the advantages of the scanner to be able to do the scans so quickly. Particularly, we can adapt our scanning protocol if we need to for patients who are very claustrophobic or in pain. That's the other aspect. Patients who've got issues with joints or their back or in pain from their prostate cancer, being able to do a very rapid scan is incredibly beneficial for their experience of the scan. I've had one of these scans myself, sat in it for an hour, while we're doing a dynamic scan. And I know how uncomfortable it can be, with your arms up above your head, trying to stay still, because any movement obviously degrades the images. So the quicker you acquire them, the less likely you are to get artifacts from movement, which is an incredible advantage of the scanner.
Yeah, and to your point, it's information can be almost a prescription against so many things. If you tell, and I'd like to come back to Will about this, like when you tell patients and you give them the times and you stick to them and you explain the why, you've got to put your hands up, but why? You've got to do this, but why, what? And that whole why, what, I think when it comes to compliance, I'd love to come back to Will on, but thank you, Kat. This is great work that you're doing. You're bringing the real human side of Scanxiety to light and underscoring the real emotional challenges patients face. So before I go back to Will, and we'll start an open dialogue after that, I'd love to just reintroduce Dr. Paul Conway as radiation oncologist. This is your job to make radiation work. We've seen it come so far through SABR and other technologies, from plain radio therapy when I started in the late 90s to now. I can't imagine what the difference is. But could you, Paul, just try and explain different sequences of the reasons for incorporating MRI, CT, PETs. I know that you do slightly different things with radiation oncology, but you have, I'm sure, this amazing understanding. So could you explain this in a really simple way for patients who are undergoing various stages of prostate cancer?
Thanks, Matt, and thank you, Will, for really setting the scene here. And I think you sort of highlighted quite a lot of the issues that a lot of people do have when they're going through these scans, and having an understanding of the different types of scans, I think, can potentially be helpful. So if I sort of take a step back and just sort of talk a little bit about the different types of scans that we've got at our eval and when we might use those through a patient journey. So firstly, we would usually split this into structural scans and into functional scans. And under the structural scan heading, we've got things like CT scans, which is computed tomography. The old name for that was computed axial tomography, which was the CAT scan, and those two words are synonymous, so CAT scan, CT scan. And this uses X-rays in an array, and as the patient passes through the machine, it takes a number of scans, and then it reconfigures this into a three-dimensional structural anatomic picture of the body, which we can then use to sort of differentiate into the spatial relationships between the different tissues. If we want to get really high definition scans, though, we really need an MRI scan, and that's a different type of structural scan that uses a high-powered magnet along with radio frequencies. And again, it reconstructs and gives us really accurate pictures within tissues and between different tissues that are sometimes of similar density on a CT scan. So it gives us much better clarity about certain areas. And then on the functional side of things, MRI does have some capabilities to show some activity, but it's really the PET PSMA, particularly in prostate cancer, PET PSMA, that's the workhorse. And the PSMA is a radioactive tracer that attaches onto prostate cancer cells, and then it's detected by the units. And again, it shows in space areas of activity, but it doesn't have structure. And so it's often combined with a scan such as a CT scan at the same time. So you get the activity scan, if you like, and then you've got the underlying structures that relates to, whether that's an area of bone or an area of a lymph node or whatever it happens to be. And so we've got these scans that are our availability, and when might we use these different scans? And I guess, Will, you took a slightly different journey by having a scan for a different reason, but a lot of men would come into the system through having an elevated PSA, and they may see a specialist urologist that may refer them on for an MRI scan as their first scan of choice. And, why do we do an MRI scan? It comes down to diagnosis, and the MRI scan doesn't diagnose, but what it does do, because it has such good high clarity pictures, it shows areas potentially within the prostate, for example, that you might want to target with biopsy so that you get the highest representation of the riskier part of the prostate cancer. Because ultimately, when you diagnose with a prostate cancer, you want to know how bad or how aggressive the disease is going to be. And the best way to do that is by targeting your biopsies to the most at-risk areas. So an MRI scan is often the first scan that we have. And of course, the MRI scan is this big magnet. The borehole is tiny, it's loud, and you have to sit there on a scanner for, sometimes up to an hour. And that's patient's first experience, and they may not get diagnosed with prostate cancer at that point. And so that's the start of, their journey. But of course, after a diagnosis of prostate cancer, we need to stage the person, and that really means how far is the disease spread. And the workhorse in this setting now is PET PSMA, but in the past it used to be CT and bone scans. But the Prostate Cancer Foundation a few years ago, in association with a large trial that was conducted around Australia, showed that PET PSMA on all measures was a better imaging modality of choice, and so much better clarity about whether the disease has spread beyond the prostate into the lymphatics or beyond. And so PET PSMA is something that we use in the initial staging, of course, but then of course, if you've had radiation treatment, whether it be brachytherapy or external beam treatment, or if you've had surgery and you have relapse, so your PSA is rising once again, we use the PET PSMA scan in that setting to try and find out why you've got a rise in your PSA. And we'll get onto this, I'm sure, but we've now got better ways of doing that.
Thank you, Paul. That's a really good overview. I appreciate that so much. Back to Will, because you briefly touched on Theranostics with PSMA there, and I remember, Will, in the August webinar, we described Theranostics, nuclear medicine, and we talked about them as symbols of hope to extend life and quality of life. Can you share more about your personal experience with what you've heard about this brave new world of Theranostics? I know we've had the webinar, but just sort of top line about your experiences, what you've heard about it, what it means, how you would explain it to other patients if they asked you what it was.
Absolutely, yeah. Theranostics, and I'm so grateful that there is research going on. That there is actually this thing called Theranostics, which is a big kind of new medical term which is happening. I actually recently only found out the real kind of detail about it in terms of who it can help and who potentially it can't help. I mean, it's, from my understanding, is that there are certain markers that you may or may not have in your prostate cancer, which will be determine whether or not you're a suitable candidate or whether or not the Theranostics will work really well for you, that field of nuclear medicine. So I think it's really important people know really up front when looking at other options is whether or not it's going to work for them, whether or not it is an option. I suppose it is this great source of hope, but I also never want people to get their hopes up too early. I think that's one of the things that I always try to temper myself with. I mean, I get this kind of feeling of, to be fair, butterflies and excitement and stuff when I hear about ideas that, wow, this is the next level to potentially a cure for someone like me, or at least a very life-extending treatment. But I always like to temper things a little bit as well. I think we should be very hopeful about Theranostics, but I think it's really important people ask questions about it if they are at that stage, and even if they're not, at least read some of the stuff on the PCFA website, ask your doctors about it, just so you're the full bottle on whether or not this is something that's going to be suitable for you in the future, what it really does mean. that's my kind of take on Theranostics at the moment, because it's this big brave new world, but I think for patients it's still very confusing right now. If I guess touch on a few of the things that Rod and Katherine and Paul talked about, it's really intriguing that I must be very good at blocking out some of the experiences that I've had when going through all the multiple scans, because as you guys were talking, I started to realize all these little memories of stuff like, having to stick your hands behind your head while you're in the machine, and how difficult it is to just not move, and that mental battle. But the why, really important. If patients know why they're doing it, then I think that gives them a real motivation to make sure they do the right things when in the machine. The other thing, I think it's PSMA PET scan. When I had my first one, the radioactive, I'm not sure if it's PSMA, I can't remember. Anyway, I had a scan, and I remember the technician told me, you're going to feel like you've peed your pants at some point during the scan. And if they hadn't told me that, and that feeling had happened, I would have freaked out. So it's all those little tiny bits of information that are given to someone before they get in there, I think that makes a huge difference. So I mean, even to the point where my last PSMA PET scan I had, my partner was heavily pregnant, so I was a little bit radioactive afterwards. So I had to stay in a spare room between the thick concrete walls for 24 hours. So just all those things that really do impact on a patient, if it's explained and described and talked about as best as humanly possible, I think that's the greatest way that can help people. And I think, people like Rod and Katherine are doing a great job at making sure that when you get into that big, horrible metal tube that does feel a bit claustrophobic, at least you know why you're there, and at least you know the benefit of being there and what the patient needs to do to make sure it can be as good as possible.
Thanks, Will. Rod, I might come to you and just ask you a little bit about, for the patients or carers, and largely, as we know, with prostate cancer, is carers who are listening into these podcasts, if they wanted to access a technology like yours, or even ask their medical team about advances, often patients do feel inhibited about asking for second opinions, or how do I get this, or how do I get access to this new scanner I've just heard about? How would you suggest, what would be your tips for patients and carers to take that conversation to their healthcare team?
Firstly, this scanner is not very widely available. There are two now, and there's one here in Melbourne. But patients always have the choice of where they go for their diagnostic test. Your referring doctor, your managing clinician can write a request form for a particular imaging provider, but it's always in the patient's power to select where they go to get access to the scans. And if it was a family member of mine, I would certainly be getting them to have the scan on this particular scanner because of its capabilities. But I think Paul touched on a really important aspect of the PSMA scan. In the first instance, is telling us the extent of disease, whether it's localized to the prostate, whether it's spread to lymph nodes, whether it's spread beyond the lymph node basin in the pelvis to other sites, because that determines the next therapy. That's one aspect, and it does that extremely well, as Paul pointed out from the PreMIT trial, which was done in Australia in multiple centres. Very important landmark publication on this particular field. But the second element is it's telling us about a biological characteristic of prostate cancer, that unlike normal prostate cells, which have very low expression of PSMA, they have some but very low, prostate cancer has very high expression of this particular target on the surface of the cells. But that also becomes a therapeutic target if we substitute the radioactive chemical that gives us the pictures on a PET scan for a particle releasing radionuclide that delivers in a very small volume radiation to the tumours. And that's the theranostic paradigm, the therapy that's driven by the diagnostics. That's the thing. The better the diagnostics, the better our ability to select patients for therapy. So it's very important to both localize and then characterize the disease, and that complementary role of the anatomical imaging, knowing where there are lumps and what the nature of those lumps are, is incredibly important, the characterization of disease. The other aspect with increasing sensitivity is that there's a lot of anxiety if you've got a very sensitive marker like PSA. You know that there's disease. And when it's increasing, you know that the disease is progressing. You do a standard scan and you can't see it, or even a PSMA PET scan on most conventional PET scans, and you don't find anything. You know there's disease somewhere, it's lurking, and you want to know whether it's going to be able to be salvaged, for example, by Paul. Has patients coming along, they've had a prostatectomy, their PSA should be unrecordable, it's recordable, and then it starts rising. We know it's there. They have a PSMA PET scan and it's negative. They've burnt one of their Medicare eligible scans for biochemical recurrence. And that puts them in a dilemma. When do I have the next one? How do I have the next one? And perhaps that's something, Paul experiences that, I'm sure, on a weekly, if not daily basis.
Yeah, it's such an important point. I mean, we're so lucky in Australia to have easy access to this technology. And, PET PSMA is very, very useful. There are, as you learn, there are different levels of technology along the way. And there are what I would call now traditional PET scanners, which are good, and then you've got sort of next level PET scanners, which are better. And Medicare currently fund in the relapse setting following a prostatectomy or radiation therapy with rising PSA. They will fund 2 scans in your lifetime, but there are so many points along the way where you might want to have a PET scan, and 2 is great, but it's it'd be great to have a few more as well. In the early relapse setting, we might be talking about prostate bed radiation therapy. Early metastatic setting, we might be talking about stereotactic radiation therapy to sites of disease to sort of starve off further next line therapies. And even once you're on, hormone therapies, if that's relapsing, you might want to have a PET scan at that point to find out where the resistant clones of disease are, et cetera, et cetera. So it's really difficult. And when we sit with patients and they've, as Rod said, you've burnt one, and particularly if you've had a negative scan, deciding when to, invoke the second covered scan is really, really tough.
We're almost at time, but I'm going to ask Kat one more question, and I'm going to ask all 4 of you, just to finish off with some take-home. But if patients are listening to this, how do they go about accessing useful information resources? Where do they go? How do they find out more about this? There's so much misinformation. How do we guide them to true information?
So I think one of the main points is that clinicians, as their first point of call, should have really good resources that they can hand to patients. PCFA website, which is a really, really good resource. And I know we're working in collaboration to create more and more books and manuals with experts in the field to actually provide really good research and evidence-based pamphlets on theranostics, on radiation therapy, as well as the hotlines that they have through PCFA are really good resources and guides. There are also websites. The APC is a really good area where they're specifically focusing on prostate cancer and really getting a lot of information out there to patients that is specific and individualized, and then talking to clinicians who are working in this field and who have a vast knowledge base and experience. And sometimes just talking to other people who have gone through a similar experience can help them just feel a little bit less anxious, because they're speaking to people that are going through the same journey or a similar journey. And if I've been through this, then someone else has also been through that, and how do we have that camaraderie? So I think using websites that are research and evidence-based that clinicians work well with, such as the PCFA website, talking to your doctors, fellow nurse consultants, and calling websites that are out there specifically targeted or geared towards helping people is helpful.
Thank you, Kat. While I understand that not everybody might have access to the MTIC service in Melbourne, I trust this information shared today with everybody has been valuable. It's noteworthy that the MTIC is the only private medical imaging provider in Victoria, utilising the quadruped CT scan technology, with 2 others available in a public system in New South Wales. So it is really an offering that you should be very proud of. Before we conclude, I'd love to ask maybe Will, and then Paul, and then Rod, and then Kat, just in one or two take home messages, how you'd like to conclude. So maybe we'll go, Will, Paul, Rod, and then Kat.
Yeah, I guess the final message I'd like to leave people with is just ask questions. If you're not sure about why you need something, or why it's taking so long to get a scan, or a particular thing you need to do before you get in the machine, or what's going to happen in the machine, just ask questions. Ask how long it's going to take, because I found that to be greatly useful. If at least you know that it's going to be a long scan, at least you can deal with it. You can deal with a lot of things as long as you know it's going to end. And if you know the time frame it's going to be, that can make it much easier. So just before you get in that machine, ask questions. If you're not sure, ask the technicians when you get there. Just find out as much information as possible, because I think if you can remove some of those unknowns, I think it can make it easier, or it certainly did for me. Just that level of realizing that I need this is going to help me, but as long as you can find out why you need to do it, and all the details around it, I think that can put people at some level of ease in a pretty horrible situation, really.
Yeah, thank you, and thank you once again for this session. We didn't touch on some of the capabilities of MTIC, and as a user of this technology and someone that refers a lot of patients through for this, when we arrange for these scans, there's always a question. There's always a clinical question that we want to answer, and if you don't know what that question is when you're going in for a scan or a blood test or whatever the investigation happens to be, if you're unsure about why that's even being done, you should ask your doctor why they're requesting that scan, so that you know what they're actually looking for and what they might change their management based on that as well. From my point of view, if I ask a clinical question, which might be, you've got a rising PSA, where is it coming from? My first thought is, where is the technology and the setup where I can get the answer to that most effectively? And, in the past, that's been usually local centers and things, but now we've got access to this fantastic technology, and the dynamic sequences, for example, after prostatectomy, allow you to see tissues before the dye comes through into the bladder, for example, and obscures everything. And so we're seeing a lot of recurrences that we've just never been able to see before, and it really is amazing sitting down with patients with the screens in front of you, walking through the scans and showing them on the screen what it is that we're actually looking for and what we found. And I think that's been it's game changing, I think, in our world, because it's really just opened a whole new window into the body and finding out what's actually going on. The answers are much clearer than they were before. So I think that's the first point, and probably my first consideration actually is getting the answers to the question that we want to ask. The second part of this process, and Will, you touched on this as well, is waiting for results. On Monday this week, we're a Thursday, by the way, but Monday this week, I saw a patient and he had a raised PSA. I sent a request form through. He was scanned the following day at MTIC, and I spoke to him the next day, yesterday. I spoke to this gentleman, and Rod rang me in the morning actually about this guy to let me know what was going on, as well as seeing the report come through. And that patient is now getting radiotherapy planning, will start treatment on Monday. And so, in terms of speed of access to scan, speed of access to the results, and the quality of the reporting and the quality of the results is lightning fast. And, by the time you've said, hey, look, there's this facility, you should pop along, have a scan, this is what we're looking for, 2 days later, you're talking to that patient with the answer. And it's fantastic to have the opportunity to have that available. So thank you, Rod, for establishing the centre, which, the technology with the Quadra combined with everything that you've done up at that centre, the light, airy room, and everything that you're doing there with Katherine as well. It really is, to my mind, the premier imaging facility in the world, and I say that without blushing. So thank you.
That's a great testimonial. For me, it's a fantastic pleasure to work with highly committed clinicians like Paul, and we've had conversations on weekends, late in the evening about patients, getting the information that may help me to give a better idea of a particular patient's diagnosis, where they've been in the course of their treatment and so forth, is incredibly important. When I set up our company, we really had 5 motivating factors. The first was to provide a world-class patient-centered clinical service. Second one was to be involved in industry-funded trials that required state-of-the-art molecular imaging technology. Third was to do our own independent research. I've spent my life as a researcher, both laboratory and clinical, and really motivated in the latter part of my career to fast track that as much as possible. The fourth pillar was really to provide advice to the various elements of the theranostic value chain, from target discovery right through to marketing of theranostic agents. And the last and most important one for me that really motivates me is education and training. This is an evolving and important field. We don't have the workforce yet to deal with this in a mature, sophisticated way. And so we're working very actively with groups like the International Centres for Precision Oncology and some of our industry partners to develop training modules that are going to help to train the workforce to make this more widely available and delivered in the most effective way possible.
Last word from you, Kat, before I wrap up.
So thanks for this fruitful discussion about Scanxiety today and how we can help our patients. First of all, I'd just like to remind patients that they are the advocates and the leaders of their own journey. So to really keep an open dialogue with your clinicians. And if there's anything that you even think is silly or you don't want to really open up about, we're here to listen. We're here to provide that compassionate ear, and we do want to help you with the best way possible so that your scanning experiences and your whole journey is made more comfortable and easy.
Matt, if I can just jump in really quickly once in as well. Paul, Rod, Kat, thank you so much, because for a patient, having those results really quickly is so vital, because I know you get out of that machine, you put your clothes back on, you walk back into the real world, and you feel like life and everything around you should stop until you get those results. The world is a weird blur. Is it going to be good news? Is it going to be bad news? You're not quite sure what to do with yourself, honestly. So the fact that you guys talk about getting results in a day, 2 days, means so much to patients. They at least know that there's going to be a quick turnaround and stuff like that. So yeah, thank you for making that happen, because those hours before you get those results, it's a weird alternate universe at times to try and just continue with normal life until you know what's going to happen. So yeah, it means a huge amount to people. So thank you.
Well, thank you. Thank you to everybody. It's been a truly brilliant discussion. We're really incredibly grateful for you all to just join us today. I wanted to thank everybody, particularly PCFA. MedWise is super proud to help support this, evident by addressing these emotional aspects of cancer imaging. It's crucial as the technology advances. Rod, Paul, Kat, Will, for all of the advice. If anybody watching this has got questions, get in touch with the PCFA by calling 1-800-2200-99 or by emailing telenurse@pcfa.org.au. Thank you for listening. Again, thank you to this amazing team, this amazing technology, and we'll see you again next time.
You can also get information from our website at MTIC.net.au. Gives more information about our team and the technology.